But what happens when you talk and the service isn't there? What happens when you go to the A&E and you're turned away? What happens when you're told that you have to wait 12 weeks for a psychiatrist and you're in a crisis? That's the reality for people. There are people who get help when they need it, but they're the minority. Most people have to keep trying and keep fighting to get access to a mental health service. And I'm one of the lucky ones. I got into the mental health service. So I feel really bad for those who don't get the help that they deserve. And it can be really difficult because when you're in a crisis, you don't feel that you deserve the help. So it makes total sense that you get turned away or that you get knocked back. We need to change this, and it's like events like this that will help bring people together. It's not good enough that the government take 15 million away from mental health services. That 15 million is lives. That's people's lives that are being taken away. And I absolutely believe that we have the capability to produce an excellent mental health service in this country, but only if the money, the resources and the time is put into it. And we need to do everything in our power to ensure that mental health funding does not suffer from any further cuts. And for me, a good service wasn't always about money. It was about someone treating me with respect. It was about someone talking to me. Someone who really listened, someone who got what I was going through. That doesn't cost money, that's just common sense. But for some reason, we've forgotten about common sense when it comes to the mental health system. And just to say thanks a million for having me chat here today, and just to say that we've all got power, we all have TDs. Use that power. That money is lives that are going to be lost to suicide, and one more life that's lost to suicide is one person too many. Thank you.
Thank you very, very much, Marie, for such a terrific and personal contribution. I'm sure that it'll ring and resonate around the room with others that have been through the system as well. Now, our next speaker is Dr. Pat Gibbons, and he is himself a psychiatrist. He's involved in the services, obviously, in Kildare and West Wicklow, based in Selbridge in County Dublin. He's worked here, he's worked in the UK, and he's worked in Central America. And I think what he's going to talk to us about is how you can achieve an integrated model of care in the community involving home care, day hospital and active outreach, the kinds of things that the two former speakers have been speaking about. So, Dr. Pat Gibbons, Kildare West Wicklow Mental Health Service, you're very welcome.
Right, good evening everybody. Thanks for inviting me along. I'm very pleased to have the opportunity to talk to you tonight about, a model of care that might meet some, at least, of the negative experiences that both June and Marie have been describing so eloquently this evening, and which some other people in the room may have also experienced as well. You'll see that the title is Innovations in Community Care. What should a good mental health service look like? I suppose I'm not suggesting that I have the answer to that question. I think there are probably many answers to that question, and that those answers will change over time, depending on particular needs in a local area or at a particular point in time. What I am going to tell you about, though, is our own experience in Selbridge, where we have developed a particular model of care that I want to tell you about. I want to talk to you about the research that we've done to evaluate the ways in which that service works, and I suppose the ways in which it doesn't work, because we're not proposing that it's a perfect service by any manner of means. And it's a service that's in continuous evolution. So in the period of time that I've been working there, which is 11 years now, the service has constantly changed, and we expect it's going to continue changing, that it will need to continue changing, because needs change over time. So let me just run through. By the way, apologies in advance. I'm going to be throwing quite a few numbers at you. The good news is, though, that all of the data that I'm going to show you tonight is available in two reports that are on the HSE website, which I'm going to show you in a moment, and I'd be very happy to provide the actual web address for those reports if anybody wants to go through any of the information in more detail in your own time. Marian, you'll be keeping an eye on the clock. Okay. I might tend to overspeak unless I'm strictly controlled. Right. Okay, excellent. I presume, do I just press the arrow, Lara? Yeah. There we go. So for the reports that we've published, these are both reports done under the auspices of the HSE, which I've been involved in, and evaluating both the cost effectiveness of the report, and that's what we call the value for money report, which was just published last year, and also the Building Blocks report, which was specifically looking at the impact of our home care service, which we launched in 2004, and we published the evaluation in 2006. So that's looking at the quality of care measures, whereas the value for money report is looking at the resource implications. Okay, and of course, like what those two reports are kind of getting at really is something that we've touched on in the earlier presentations, which is this question about resources and quality, and whether or not, where there are problems with the quality of service, and we've heard, earlier on, how many problems there are with the quality of service, specifically in relation to how to access service in a crisis. But is that purely down to a lack of resource? And Marie was pointing out that there's certainly a huge resource element to that, but is that the only question, or are there difficulties with how the services are actually structured, which aren't necessarily purely resource issues, but have to do with structures and how systems are operated? The value for money report, which again which Lara had mentioned earlier on in June as well, is our kind of broad vision or map for what services are supposed to look like. But in terms of, obviously we've made very little progress in terms of reshaping services to look like what Vision for Change describes. And the question is, again, is that about just purely the lack of resource, which does exist, or are there other ways of getting around that within the existing resource? So I'm going to talk a little bit more about that as we go through. Just an interesting point that I came across when I was doing the research for the Value for Money report, and this is from HSE data, that there was actually a very significant increase, a tripling of spending in mental health between 1997 and 2009. And I suppose the question that arises, for that triple expenditure, did anybody notice a tripling of the quality and quantity of care provided? And I think that's something that we certainly didn't really experience in any sense. So where did that money go? Let's come back to that maybe later on. I suppose the last comment is never let a good crisis go to waste. You've probably heard that a lot during this current recession, but there is actually something to that, because when a system is under stress, and the health service obviously is under a lot of stress right now, it is also a time for maybe introducing more radical changes than we would otherwise be prepared to consider when things are perhaps running more smoothly from the resource point of view. Okay. This is something that many people in the room will know already, but there have been a number of studies from the Mental Health Commission looking at what sort of service do people want, or what do they want their service to look like? And people want to talk about a service that provides easy access, and that's both for non-urgent but also for crisis difficulties. Having a continuity of contact, in other words, that they're not seeing a different person every time they come to the clinic to talk about their difficulties. They want information about both the nature of the experiences that they're going through, but also the different treatment options that are available. People want to be involved in the decisions that are being made in relation to their treatment. They want to have choice, so there's a range of treatment options. And again, Marie was talking about how there can be an enormous lack of options, and often medication is the fallback position, with a lack of alternatives such as psychotherapeutic or social interventions. People want time, and again, we've heard reference to how short the time that people may have to talk about their difficulties, to explain their life story, and to put those difficulties into some sort of context. There's a lot of consideration as well around family support, and many family members, I don't know if there's family members in the audience this evening, but again, will have the experience of perhaps feeling very excluded from a process which very much affects them in terms of their family life and their personal lives, but which they feel they don't have an opportunity to contribute or to participate in, and that's an enormous problem for families. Okay, just a very brief word about where, the context for the service that I'm describing to you this evening. Kildare, West Wicklow looks after really quite a largely, I suppose, suburban population, about 220,000 people now. Our inpatient unit is in Naas Hospital. It's called the Lakeview unit. It has 29 beds. It's by far the least provisioned service nationwide in terms of the number of beds per head of population. It's probably about half what would be recommended in Vision for Change. The area that I work in is in the north of the county and has a catchment area population of 70,000. It's mostly suburban, and I've just briefly described what the membership of the team that I work with, which has a home care team. There's also CNS, refers to clinical nurse specialists, which do the active outreach for people who are attending the service on an ongoing basis. We have a day hospital, a day centre. There's 2 consultants, there's a senior registrar, 4 junior doctors, 2 social workers, 2 OTs and 2 psychologists. It's quite a large group of clinicians, as you can imagine, as you can see, and it's divided into 2 separate teams, which are headed by each of the consultants, one of whom is myself. Okay, just to run you through the pathway through care, and this is just to give you some idea as to what, I suppose, what the journey is like for somebody who presents in difficulty. The referrals are usually made by the GPs, and although they sometimes come from the A&E department, sometimes people can self-present to an A&E department, but most of the referrals will come through the GPs. They'll be reviewed by ourselves. We will be clear from the referral, whether it's GP or A&E, how urgent the referral is, and the length of time that the person will wait for an appointment will depend on the urgency. If it's very urgent, it can be same-day appointment, or if it's non-urgent, it will usually be maybe 4 to 6 weeks. That would be for a regular routine appointment. The initial assessment is by the junior doctor, and that's just a discussion, I suppose, an overall review of the person's current difficulties and their overall life story. Once we've had that initial assessment, then we'll refer the person on for a multidisciplinary assessment, a lot of which is carried out by the nurse, and which will involve kind of routine assessments, standardized measures for measuring depression, psychosis, or whatever symptom area the person is running into difficulty. It will also involve an interview with family members. Now, that obviously does depend on the consent of the person concerned, which is very important, but we do work very hard to explain and reassure the person that it's not about trying to take control from them, but really to bring the family in to give them an opportunity to participate and, I suppose, to contribute to supporting the person in their recovery. At that stage, once we've done all, the overall battery of assessments will be complete, then the person will be reviewed by the consultant, which in my team is myself, obviously, and I will review the complete assessment and everything that we've learned so far about the person. I'll go through the whole story with the person again to make sure that we're absolutely clear as to what the combination of difficulties might be. At that point then, once we've gathered all the information, we'll sit down as a team. So that means with our occupational therapist, our social worker, our psychologist, nurse, and the doctor concerned, and we'll review the whole story inside out as a group. So we'll sit around the table, we'll tease out the story, about an hour we'll have, for each person. And that, I suppose, allows us to bring in the multidisciplinary contribution to making sense of the person's story, and also then to contribute to actually imagining what sort of interventions might be helpful to help this person in their recovery. So that it's kind of trying to move away from this kind of more strictly medical or medication orientated approach that Marie was describing earlier on, to something that's more comprehensive and that is more holistic and looks at the other key areas, which are often psychological, social, economic, etc., and to incorporate those into the care plan. Once we've done that, the care actions that the team needs to take part are then identified and allocated to team members. We'll discuss it with the person themselves and go through, we have a kind of a formal feedback and discussion session where the person can interact with their care plan and can, I suppose, work with their key worker to mould it more specifically to how they feel what they need to do to recover. The interventions will be delivered, reviewed, and then discharged. And the idea is that the team is tracking the person through that process very actively all the way through to make sure that the person doesn't get stuck in the service. And Marie was making the point earlier on that a lot of people can get stuck in routine services where there's an entry point, but there's no very clear exit point. And sometimes people are attending services for years and years, not necessarily with a clear benefit to themselves in doing so. And obviously it can waste a lot of resources for a stressed service as well. We've gone through, that's the case formulation is just the multidisciplinary review of what the person's difficulties are. I'll just maybe skip that. The care planning I've pretty much described already, so I'm going to skip that as well. That's what the treatment and care plan, in terms of the areas that it looks at, we'll be looking at the primary, treatment for the primary diagnosis, whether it's depression or psychosis or whatever, anxiety, whatever other specific areas of, specific diagnosis the person may have. And that will include not only medication, but may or may not include medication. For many patients, we don't actually use medication because it's not really relevant or appropriate, but we'll certainly have a psychoeducational input and a supportive input. We'll look at whether there are personality issues that, or psychological issues, I guess we can say, that might need a psychological intervention, whether there's addiction issues, whether there are difficulties for the person in actually engaging with the plan and working towards their recovery, if there's physical health issues that are relevant, social needs and need for social support or extending that, work issues, risk issues, and then family issues and looking at support for family members in promoting recovery. In terms of the evaluation then, what we found from and this is from our building blocks report that I told you about earlier on, we found that the overall admission rates using this approach were hugely reduced and much lower than the comparative areas within the Kildare service which we compared our service to. There was a significant reduction in symptom scores such as standardized measures of depression and anxiety, so that's suggesting that this is a clinically effective way of working. We did measure, we had a formal measure of satisfaction using standardized kind of satisfaction rating scales, both of service users and family members. And again, we found that the scores were overall better compared to our neighbouring services. So that's both for service users and for carers, with and a reduced measure of family burden, which means the pressure that the family members felt under was also less with this comprehensive community service compared to the standard service. And again, when we talked to people, because again we had a qualitative aspect to our evaluation report, which is really sitting down and talking to people in face-to-face interviews and trying to tease out with them like why they thought this was a more helpful way of working and what was it about this way of working that they found particularly useful to them. And the things that they brought home to us in their feedback was that they felt they had a much better relationship with the team, and especially with their key worker, usually was the home care nurse. So this was the continuity issue that I'd mentioned earlier on, and we have a strict key worker system where where there is an identified member of the team who is responsible for coordinating all of the care interventions for that person, so that they know exactly who they need to turn to if they have a particular problem or have difficulty accessing a service or whatever, or if they have a need for crisis support. They felt that they had more time to, again, because of the key worker system, that they had an identified person who was responsible to provide them with whatever time they needed to address whatever the difficulty was. They had more access to information and support, and that was for both service users and family members. And in fact, we've built on that since to develop a formal education and information program called the OLIS program, which we're implementing and which we're rolling out in the Dublin area at the moment. In terms of staff, we again did interviews and we found that staff members felt that they had much greater autonomy, a greater responsibility, but as a result of that, a greater level of job satisfaction in this way of working. And GPs reported that they had a greater level of access or an easier access for GPs to services. We were hearing earlier on about the difficulties that GPs can have with the lottery, the postcode lottery and all this sort of thing, but where there are kind of clear I suppose, access protocols and guidelines and clear methods of access that are communicated to the GPs. And once the service actually follows through and is available in the way that we claim to be, then obviously this works well for GPs and they know exactly what to do when they need to refer a person, whether in crisis or routine. Okay, so then just the highlights then. As I mentioned, the key worker system is a real priority for us. That's really important that there is one identified individual who's responsible for coordinating care. It decreases the risk that there will be people will slip through the cracks, or that particular interventions will be missed or forgotten about or get lost somewhere along the way, because this person has a care plan to operate to. The key worker, that will guide them through the interventions, so they'll be much less likely to lose their way in supporting the person. There's a greater sense of partnership and collaboration within the team. There's a focus on operationalized guidelines, in other words, describing very clearly what our protocols and guidelines are for dealing with the whole range of complex situations that can arise in providing mental health care. The team itself is continuously reviewing what we're doing and looking for new ways of tackling problems. And this is where we've developed, for example, I'd mentioned about the OLIS information program, because there was an identified need. There wasn't a program to address that need, so we said, well, we better just go and make one. And that's what we did. And similarly in providing psychological interventions, for example, for personality difficulties, again, there wasn't a program available, so we identified a particular therapy program, went and trained for it, and then started providing that program as well. So this is the sort of, I suppose, when you have a team that's more actively engaged with problem solving, then you're more likely to actually identify solutions to the kind of structural problems that can prevent good quality of care. It has also led to a much greater focus on the service user being involved in their own care plan and actually contributing, shaping and responding to their care plan, and also a much greater emphasis on involving families as part of the the support team for the person in difficulty. Okay, so, you know, I suppose that all sounds great, and you would say, like, gosh, isn't that easy it's easy for the team in North Kildare to provide that level of service, because look at all the clinicians that they have. They have psychologists and OTs and all sorts of things that other services don't have, and that's a very fair question. So that's where the value for money report comes in. It kind of looks at, well, look, what are the resource implications in trying to provide this sort of care? So we went and we looked at that, because there's very little data available, and we had to just go and collect it. What we did was then compared this model of care that I've described to our sister service, so within the same umbrella of services, but in the other area, it's a more traditional, more hospital-focused rather than a community-focused model of care. And there's just a little bit of information about the actual research itself, but I think you might be more interested in the findings than the background to the research. Basically, we were looking at the Selbridge area is the community model service. You see that column there on the right-hand side? And the inpatient model service is the more kind of traditional hospital-focused model, which is probably still the model that's operational in most of the country. You'll see that the hospital area had a bigger population than the Selbridge area, but we had actually slightly more assessments to do. So we had a higher referral rate than the other area, but we had much lower inpatient admissions, 41 compared to 131. We had a hugely less number of bed days utilised by a factor of almost 10. So we only had about 15% of the bed days that the other area had. We had much fewer long-term attenders in the OPD. Do you remember I was talking about people getting stuck in the service? And you can see that in the inpatient model service, a lot of people were just getting stuck. And when we went and looked at what their clinical care needs were, they didn't need to be in the service. You know, there wasn't any long-term severe mental health difficulty that would have required them to remain in contact with the service. It's just that they hadn't actually gotten the service that they needed. They should, you know, and then progressed out of care. They'd kind of just gotten stuck and were in kind of limbo in a way. And then when you look at the cost, which is the kind of the key figure that we were looking at in this study, you can see that despite the fact that the community level service had a lot of resource in the community, the cost is less. So how does that happen? Well, the main reason, I suppose there are two main reasons that we came up with when we looked at this. One is that hospital care is really expensive. It costs, depending on the hospital, but somewhere in the region of 150 to 200,000 euro per year to maintain a hospital bed. That's a vast amount of money, and you can buy a lot of nurses and a lot of psychologists and so forth for 200,000 euro. And the other thing is that when you do have a community service, if you're looking after people who are stuck in the service and who probably shouldn't be attending there in the first place, then you're wasting a lot of your precious resource, not doing anything very useful with it, if you know what I mean. So that's the reason why, if you refocus away from the hospital-based service towards a more comprehensive community service, you can afford, with the savings, to employ the multidisciplinary team that will allow you to provide a really high-quality, comprehensive, multidisciplinary service to the patient or to the person in their own community. So then when we looked at the quality, again, we reviewed the relative quality of the two services under the auspices of this value for money reports. Like, okay, well, look, like, are people really getting a better deal or a worse deal? Like, it costs a little bit less, but are they getting the service that we say they're getting? So when we looked at things like access, there were shorter waiting times in the community service. There were much fewer A&E assessments. And this is picking up on the main topic for today's discussion. So if you don't mind, I'm just going to take 1 minute to explain that. The reason why there are much fewer A&E assessments is because the community, because we've invested our resource in the community, it's a 7-day service. There is we have the capacity to provide a rapid response because we have the team sitting in the community centre doing their work, available to pick up on referrals from the GPs and respond to them in the community within the same day if necessary. So we very much discouraged our doctors, our local GPs, from sending patients to the A&E department. We say, no, don't send them to the A&E department, send us the facts. And we have we have a very strict protocol as to how they do that. There's a fax and there's a referral form and it's all very standardized. We have a mobile phone number that is carried by one of our home care nurses that the doctor can just ring up. So it couldn't be easier. They just literally fax in the form, they dial the number, a nurse will answer, hello, how can I help you? I've just faxed in a referral in relation to Joe Bloggs, who is suffering from depression. I'm worried that he might be at risk. Could you see him today? Okay, no problem. Let me check. I'll make an appointment and I'll get back to you. So it's as simple as that. And it avoids the A&E department. It's much better from the team's point of view, because you don't waste a resource having the person seen by a doctor in A&E whom they'll never see again. So that's a bit of a waste of an assessment. They will come to the service who will be looking after them afterwards anyway. They will be seen by a doctor who will continue to see them over the weeks and months of their assessment, and who is part of the team that will continue their care. So everything kind of fits much more together, it's knitted much better together, and it avoids all of the awful experiences that people have when in distress and when hanging around the A&E department. Okay, there's a much more lower rate of hospital admission and shorter length of stay. We've heard of that earlier on. There's a greater role for families in assessment, greater use of formal assessment tools and standardised assessments, which is really important to maintaining the quality of care. And there's a more structured pathway through care that we described earlier on. Just a couple of very brief things then. In terms of looking at the national figures, because there is some national data. We've heard earlier on that when June was looking for some data, the HSE wasn't able to give it to her. And I'm afraid, unfortunately, in many aspects of mental health care, that is still the case. I think at last the HSE is now realising how important it is to have data in order to be able to compare services and work out which models work best. You need information to do that. So there's the beginnings of a move towards collecting this sort of data, but to date, up until now, there's been very little. Dr. Daly and Walsh, this is from the HRB, do have some data though, which we've used to compare how our community service model looks compared to national data. So just ignore the middle column. And again, if you look at the community orientated service and the national data, you'll see that again, maybe start at the bottom line, and you'll see that overall our mental health expenditure, and this is from 2009, is €180 per person nationwide in the country. Our service, which looks kind of fancy with psychologists and bells and whistles of all sorts, it only costs €45 per year, and that's because we don't need to use the hospital, so we save an absolute fortune, and so we feel that completely justifies investing that resource in the community. And if we go back up the column, then what that means in effect is we have a much lower admission rate. As you can see, it's about a fifth of the national rate. We have a much lower first admission rate. That's for people who've never been in hospital before, so it's much less likely to happen in North Kildare than elsewhere. Much lower readmission rate, much lower about a 50% lower involuntary admission rate, so you're much less likely to end up being admitted against your will, which is a very distressing experience for many people, of course. Much shorter length of stay if you do get admitted. Much less likely to need a long-term care, because we have the resource in the community to allow even people who are quite ill can be discharged home to continue their recovery at home. And as we said, the cost is much less. So I'm going to leave it at that because I'm running out of time. If there's any other questions, I guess we can pick them up in the Q&A. So just wanted to really thank you very much for your attention, and leave it at that. Thank you.
There's another person going to join us who is involved with mental health reform herself, and we will start. Shari McDaid is her name. She's MHR Director, and you're very welcome indeed to the. Do you want to say something very briefly, or will we go straight to the Q&A?
No, I mean, I think I'd just like to thank all the contributors so far. I think they've all been very informative and really painted a very clear picture for us of what some of the issues are. And we wanted to open this space to people to be able to share their experiences and their concerns. And what we have the opportunity to do as mental health reform is to feed back to Minister Lynch, to feed back to the HSE, that the kind of general perspective that we can take away from an evening like this about the kinds of changes that people want to see.
Right.
So that's
okay.
Anything I can do to help.
Well, as Marie said, everybody has a TD, or 2 or 3. But anyway, now do you know what happens normally? People sit there because they're very polite, and they figure they let somebody else start the whole show, And then we'll be coming to the end of the time, and a sea of hands will go up, and you'll say, damn it, I never got the chance to say what I wanted to say. So, can I ask anybody to put up a hand and start it for us this evening? Certain lady here in the front, yeah.
Can I ask, is his program a pilot program, or is there a similar program anywhere else in the country?
The question is the